So welcome everybody to this edition of Lipid Insights. I'm Dr. Alan Brown, past president of the National Lipid Association and director of the Lipid Clinic for Advocate Healthcare. I thank you all for joining us today. I'm going to be discussing with Dr. Jessica Pena and Dr. Marlis Koschinsky a recent document that was published in the journal Clinical Lipidology. And the title is intriguing. It's called What's Next for Lp(a), a National Lipid Association report from an expert panel discussion. And this is labeled as a clinical lipidology expert discussion. So it's not a guideline, it's a discussion of experts in the area of Lp(a). I've read the document. I found it intriguing for a couple of reasons. There are a lot of things that we know about Lp(a), but there are many unanswered questions. And I thought the document beautifully laid out the questions that still need to be answered. And it's a nice add-on to the recent paper that kind of was an update on the Lp(a) science and what we can do for elevated Lp(a) in the current era while we're awaiting other clinical trials. So Dr. Pena, Dr. Koschinsky, thank you so much for joining us today for this discussion.
Well, thank you for having me.
Yes, thank you, Alan. It's great to be here and looking forward to the discussion.
Well, we couldn't have two better experts regarding Lp(a). So I guess I'll start with Jessica. Maybe you can tell us a little bit about what was the background for even doing this document, which is really kind of a discussion of what we know and what we don't know.
Yes, I think the purpose of this this document seems a little simple, though I think was needed was just to have a group of experts around the table at the same time talking about, with an extended period of time, talking about, the unmet needs in the field and unanswered questions and to share knowledge. I think what was unique about it was that it was a real multidisciplinary group. So we had basic scientists, clinicians, primary care doctors, cardiologists, endocrinologists. So really a multidisciplinary group of people sharing ideas and also just thinking about future directions and what we would want to know if we could know everything.
Yeah, that's timely because probably within a year we're going to have our first secondary outcome trial. So we're all looking forward to that. And Marlis, I noticed the first section in the paper was about actually the metabolism and assembly of Lp(a). And, I guess I sort of had an idea of the details of Lp(a) assembly and completely confused about clearance. So it sounds like I'm not the only one. Maybe you could tell us a little bit about what we know and what you felt was important to put into the outstanding questions section on the actual kinetics of Lp(a).
Well, I'll start with that, with the catabolism, because that indeed is probably the murkiest aspect, relative to what we know about the assembly. And I'll loop back around to the assembly in a minute. But the catabolism, it's been quite clear for many years, for decades, in fact, that it's the liver is the site of catabolism, and specifically, likely, the hepatocytes. And, just because of the similarity between LPA and LDL, it's caused sometimes a tendency to oversimplify or, just expect, well, it's going to be the same as, the catabolism of LDL. And we know that's not quite true. It's not quite as simple as that. The role for the LDL receptor, for example, in catabolism of LPA remains relatively controversial. And it looks like it could be context dependent, which makes it even more complicated. So it's not a simple answer. We haven't yet found, the LPA receptor is this, or it's this particular receptor. We just don't know. And I think it depends on perhaps factors like how much competing LDL that there is, whether or not the LPA could actually, use the LDL receptor as a route of removal. For example, that's one sort of thing to think about. And, the other thing to think about is the differences between LPA and LDL, which people always forget when they're having these discussions. So it's got also the ApoA component to it, which is, bears a high degree of similarity to plasminogen. So what about the ApoA part of LPA driving the catabolic pathway through some specific, receptor interactions again on the hepatocytes? So, we just don't know, and it's never been a straightforward slam dunk answer, and we're still grappling with it. But I think we have to accept, I think the way forward is to accept that it's going to be nuanced. It's not simple, and just embrace the complexity, and for people like me to continue doing the fundamental research in our labs to tease this out, because it's an important question. And, again, on the flip side of the coin, we know a whole lot more about the assembly of the particle. So in other words, the production piece, than we do about the removal. So I can say a little bit about that if you want, Alan, about the assembly.
Well, it's important, right? Especially now since
Yes.
we're still confused about clearance, our new therapies
Yes.
are focusing on assembly, right? So maybe tell us a little bit about that.
Sure. So the assembly of the LPA particle is a two-step process that we identified many, many years ago as being two steps. And the first step occurs, again, within the cell, within the hepatocyte. And it's the first interaction is a non-covalent interaction with ApoB100 on, I don't want to call it an LDL particle because it isn't, because we know the liver doesn't make LDL. So, but it's something that resembles LDL in that it will have an ApoB100, but we don't know much about the lipidation status and so forth. But anyway, that initial non-covalent interaction occurs very early in the secretory pathway, and in fact is restricted to the intracellular environment. Okay, so that step happens inside the cells. When that non-covalent complex leaves the cell and either associates with the cell surface or very close to the hepatocytes, the second step, or the covalent bond formation, occurs to create that disulfide linked LPA particle that circulates. So what's been really interesting about this is that muvalaplin, which I think you were maybe referring to, Alan. Muvalaplin is a new compound that's in phase 2 trials, and it interferes with that first non-covalent step of assembly. Okay, so if you don't have that step, you don't get the covalent bond, and so you don't get an LPA, or you get reduced amount of LPA particles circulating. So that was really based completely on our understanding of the process and which, parts of the ApoB100 and the ApoA are important, targeting that interaction. And again, it was quite edifying for me because it really validates what we had found and how we understand that process to occur. Now, muvalaplin is in early phases. It is a small molecule, which, may have some advantages in the future if the drug turns out to, to be able to move along in clinical trials, depending on what happens in phase 2. So it's an exciting time because it's the first time we've actually used a mechanism to design a drug based on a mechanism that we know for LPA. The siRNAs and the ASOs are not really mechanism dependent. You can, you don't need to know how something works to reduce its levels with an ASO or an siRNA. So muvalaplin is interesting in that way. And, it's an exciting time in the field. And as you said, Alan, with all these drugs coming, to fruition in terms of results and reporting of the randomized clinical trials, and we'll see what happens.
Yeah, and we got one antisense oligonucleotide and two siRNAs that are far
Correct.
along in clinical outcome trials. So probably next year we're going to see the first antisense
Yep.
oligonucleotide data. And
Yeah.
I guess, Jessica, there's been a lot of discussion over the years about uh, the mechanism of atherogenicity of LP little a, highly oxidized particle, pro-inflammatory. And then there's the discussion about thrombosis, which, in humans it seems a little elusive to prove that. There's some data in animal models, but where are we with the thrombotic risk of LP little a?
Well, yes, that's, I guess, an outstanding question, and one that we think that there's a prothrombotic part of LP little a. I think that's underscored by some of the observations of its role in stroke, for example, in the pediatric population where atherosclerosis isn't really at play. And I think some of the difficulty with this is as Marlis mentioned, it's an independent risk factor, but it doesn't operate by itself. It needs, right, it operates with, in the context of other risk factors and atherosclerosis that's already developed. So is there, what's the role in, in the early development of atherosclerosis, or does it need, how does it interact with, with established plaque? So I think these are all questions. Of course, the other observation that aspirin may be of benefit in individuals with a genetically predicted elevated LP little a also, I think, hints towards that, prothrombotic mechanism. And so I think that this is hopefully something that we'll, continue to learn about. It's not considered a risk factor for venous thromboembolism. But I think that most of us think that there are, there's a prothrombotic effect.
So there are a couple of other drugs that are effective in lowering LP little a. And Marlis, I wanted to ask you about one in particular. So CETP inhibitors seem to really lower LP little a, and with some of the CETP, there's at least one or two still out there, one in development that lowers LP little a quite a bit. Do you have any idea what the mechanism of that is, and any thoughts about whether that would give additional benefit?
First of all, I have really struggled to understand the mechanism, as I think many of us do, for how, CTP inhibitors in general can lower LPA. And the most recent one under development is interesting in that I think it has a much higher LPA lowering effect than previous CETP inhibitors that looked at LPA lowering. That was kind of hovering around 40%. And I think this newly developed one that's kind of progressing along, in addition to being very effective, obviously, in lowering LDL, is also more effective, in fact, for unknown reasons in lowering LPA. And I think it can lower maybe up to 66% or 67%, which is really good compared to previous versions of the same type of mechanism of action molecule. So, again, I'm fascinated by it. I don't know. And again, sometimes, in a field like this, it's a bit of the tail wagging the dog in terms of, okay, so now we've got that observation. It's very effective. Now, as a fundamental scientist, we need to feed back and say, okay, how is it working? And for me, the excitement is, what more does it tell me about the fundamental, metabolism of LPA, which is really what, my research is focused on. So I'm excited and, would already thinking of things that we could do to try to tease that out. But it's a very good question, Alan, and I have to say, I'm just not sure.
Yeah, it's fascinating. It might give some clues to
Yes.
metabolism.
Yes.
We're talking about obicetrapib, which is in
Yes.
development still, but has, quite effective lowering of LP little a. So let's talk a little bit about the clinical issues. I mean, we've all been to many lectures on LP little a as a risk factor. And, I always say that if a horizontal earlobe crease is a risk, cutting off the earlobe doesn't necessarily change the risk. So we're obligated to show that lowering LP little a actually translates into lower risk. And as you both know, we've got these at least three clinical outcome trials underway with 3 different drugs. The dilemma that Jessica, I want to ask you about is, if you come in with the elevated LP little a and you have a calcium score of 0, the level of LP little a really doesn't seem to correlate much with risk. And yet, we have lots of people worried about it. 20% of the population have an elevated LP little a. And I don't want to discount that risk. So how do you think about it in the clinic when a patient comes in and maybe they've got a relative who had early heart disease and they've got high LP little a, both in the adult and maybe in the adolescent or young teen?
Sure, I think that's that's a common referral. So I think we're now seeing, I think fortunately we're seeing more testing of LP little a. I'll say, definitely in the past year that many more patients have been coming in asking, what's my LP little a level? I have a family history of early heart disease, and so they're asking for these discussions. I think it's an individual one, Alan, with every patient. I think there are patients where, if there's a family history or, a dramatic event in a relative, those patients want to be aggressive about lowering their risk. Those are situations where they want to look at all their risk factors, and we're talking about, blood pressure, their, ApoB, HSCRP and their inflammatory risk, and thinking about all the ways that they can address those and being aggressive about those. And so there are some patients where, despite a 0 calcium score, they may elect to start pharmacotherapy to lower their ApoB. And I think that's very reasonable for someone trying to be aggressive about lowering risk. The interesting thing about LP little a is that it is an independent risk factor. And so even now recently published was the 30-year follow-up from the Women's Health Study, LDL, cholesterol, HSCRP and LP little a, showing that there was this, that it continued. And although we talk about 5 and 10-year risk, when we're seeing young people, they're not, they're thinking about their lifetime of risk, and want to be aggressive about that. So I think it very much depends on the individual. And there are other people for whom, the disutility of taking a medication for the rest of for the foreseeable future is important, and they're not willing to do that. So I think there's not a one size fits all for this. And this is why I think, we'll continue to have these discussions. So hopefully informed by more, outcomes data. I'm excited that one of the studies is enrolling patients with familial hypercholesterolemia, so not purely secondary prevention. And so hopefully we'll be able to, learn some more about primary prevention and hopefully eventually primordial prevention.
Yeah, and interestingly, one of the trials I think is enrolling patients with elevated coronary calcium scores, significantly elevated, but because I suspect that when these medications come to the market, and I have no idea what they're going to cost, that based on the clinical outcome trials being primarily secondary prevention, it would be difficult to use them for the foreseeable future in someone who you worry about for primary prevention. So maybe the elevated calcium score piece will allow us to identify patients that haven't had an event yet, since we all want to reduce events and prevent them from occurring in the first place, right?
Yeah, sure. That's the question. Is it the same threshold? Do you need for primary prevention, where the absolute risk is different? That's the question. You can't extrapolate the secondary prevention data necessarily.
Right. So, Marlis, I want to ask you a mechanistic question on this topic. Some people have high LP little a's and they live to an old age and don't have a problem, even though population-wise there is a significant increased risk across the broad population. Do you have any thoughts as to why? Maybe is it because we're measuring it primarily in milligrams per deciliter and animals a better assessment of risk, or is there something to do with the size of the particles or numbers of the particles that might contribute to risk that we haven't quite sorted out yet?
Well, that is a really good question and one that people always ask. But it's just not exactly clear. And I think once we start getting better understanding from, kind of what role is LPA playing in disease? Like, is it the initiation phase of cardiovascular disease? Is that where it's playing a role? And again, my idea is that and this is, full disclosure, my own personal viewpoint is that we don't have much of an idea of, the LPA particle itself, how it differs in different people, even with the same levels of LPA. So what I'm getting at here is any kind of heterogeneity with respect to the lipid composition, with respect to the proteome in different people. What proteins is it carting along with it? And do those track, as well as the LPA? We just don't know. We know, and to your point about measurement, I think we're pretty happy now, to say that we can use the existing measurements, be they in mg per deciliter and animals per liter. We feel that the tests are adequate to certainly identify at-risk individuals. And I mean, Jessica, you jump in if I'm going out of my wheelhouse here, but that's just my feeling. And so I'm not so worried about that as I am now focusing my thoughts and my attention scientifically on what are these differences that could exist. We know levels are different. We got that. We understand that. And that relationship with risk. But again, what is circulating around in people who have high LPA and no disease, no family history of disease, versus people who have the same levels, who have a strong family history of disease and themselves have premature disease? That's kind of what I want to start focusing on. I think we're there in the field that we have to start asking those questions. And especially as drugs come into the fray, as you mentioned, we're going to see the first outcomes trial probably within the first half of next year, the results of that. And again, we have to be prepared to think, who's getting these drugs? Is there a way that we can be more precise?
Yeah, that's very helpful. And I certainly, for the audience sake, I don't want to disparage the importance of looking at Lp(a) as an independent risk factor. Jessica already pointed out that it is an independent risk factor, and we can identify many people that currently aren't being identified as being at significant risk for cardiovascular disease. But as was well pointed out in the document that you both contributed to, there's still a lot of questions, and it's appropriate to ask those questions, which brings up an issue that probably many of our colleagues don't think about much, which is the aortic stenosis issue. And that was, discussed nicely in the paper. So Jessica, maybe you could tell us a little bit about, do we know the mechanism of Lp(a) increasing the progression of aortic stenosis? Should we get an Lp(a) on everybody with aortic valve disease? And then the last question, which is a bit controversial, but there was a recent paper suggesting that even in bioprosthetic valves with elevated Lp(a), there might be an effect on deterioration of a bioprosthetic valve. So that's a lot to ask, but Jessica, why don't you tell us your thoughts on that?
Well, I think more to come on the mechanism. Hopefully we'll learn from the outcome study. If there's, hopefully, as Marlis was mentioning, we can learn from the outcome studies about the pathobiology there. The second question
was just,
should we measure? Yes, should we measure
yeah,
everyone?
should
Yeah.
we measure it in everybody with aortic valve disease? Should that be? should that prompt us to do echoes a little more frequently, for example?
For sure.
And just a comment about the link between Lp(a) and aortic stenosis, because I think many times people don't think about that.
Yes, absolutely. I think it's one that's often forgotten. Yeah. We talked a lot about in our group about, how to enhance screening and, practical ways of doing so. And certainly there was a group where they perform LPA screening as part of a TAVR, or transcatheter aortic valve replacement evaluation, and how that has been very helpful in identifying individuals with elevated Lp(a). And so I think anything we can do, both focus screening and, this screening everyone is aspirational, but anything we can do to identify individuals in these high-risk groups, I think would be valuable, with aortic stenosis being an important one, not just again for the incidence of aortic stenosis, but for the progression of aortic stenosis. We know that individuals with high Lp(a) are at higher risk for faster progression. And so those are individuals that I keep a closer eye on. And certainly if they have known aortic calcification, we'll make a note of that. And I think that's a valuable teaching point, in identifying individuals. I think another question that sometimes comes up is whether, all individuals with a high Lp(a) should have an echocardiogram. I don't think that that's, there's any recommendation to do that, but certainly the physical exam, I think we have to at least start with examining.
Yeah, running a lipid clinic, and being a cardiologist, when I hear a murmur and I've got a patient in my lipid clinic, that's just one more prompt to get an Lp(a) level. And I tend to order echoes a little more frequently if they have moderate aortic stenosis and an elevated Lp(a). I know some work that I was confused about suggests possibly the pathology of the increased risk for calcification of the aortic valve. Marlis, can you help us with that? I remember reading a couple papers suggesting that the Lp(a) somehow transports proteins into the valve and increases the risk for sclerosis of the valve, but I don't have a perfect memory of that, so I'm going to ask you.
Well, I mean, I think one of the things that we've come to realize that's fairly well established is, in both atherosclerotic disease and calcific aortic valve disease, even though, people think of them as quite different, LPA, and why is LPA contributing to both? How does that happen? And I think the answer that we came up with is the common link is this highly pro-inflammatory nature of LPA particles. They're highly pro-inflammatory compared to LDL particles. So that, that can trigger in different, in different contexts, a different kind of cascade of events that, in one case, you develop an atherosclerotic plaque. And in the case of the valves, you develop calcific aortic valve disease. But the initiation of the disease and the progression of it, I think, most of us would agree is largely reflective of the highly pro-inflammatory nature of LPA. So it seems like, well, how can it contribute to valve disease and atherosclerosis? They're different types of diseases. But really, there's commonalities in terms of responses to inflammation. And that's what I think that we're seeing in both of those cases. And I think more work obviously needs to be done to understand, the specifics of, exactly what's happening. Are there, some differences in signaling pathways and things like that in the valves? But I think overall, it's a story of inflammation. I don't think that really answered your question.
No, it's helpful.
But so you wondered about things being brought in. Well, certainly the oxidized phospholipids per se trigger a variety of different signaling pathways in both of these vascular beds. And, there is evidence that, LPA can carry things like autotaxin I think that's maybe what you're thinking about, that can, in turn promote specifically valve disease. And so, stay tuned. This is all work that's ongoing, but I think that kind of umbrella of a highly pro-inflammatory particle is one that we should keep in mind, because I think that's the key why, LPA is, there was a recent publication, what is it, 6 times more atherogenic than, the comparable concentration of LDL. That's been attributed potentially to all of the oxidized phospholipids that are being carried on LPA, preferentially.
So this has been a great discussion. And again, I don't want our audience to think that we're so confused about LP little a that we shouldn't measure it. So I'm going to ask both of you to give us a summary, because I think we've suffered for a lot of years with doctors not ordering it. I can't tell you how many of my patients have said they asked their physician about LP little a and they were told, we don't get that test because there's nothing we can do about it. Even in an era, which has been around for quite some time, that if we lower LDL, or ApoB, we can show benefit in reducing risk. So with that said, I thought this was a very intellectually honest paper that asks all the right questions that are still unanswered in an era where now what we're reading is a lot of information about what we do know, that on a population level, that the levels of LDL are associated with risk. They're an independent risk factor, and we're getting excited about therapies. So with that introduction, I'd like to ask you both, I'll start with Jessica, what do you think the most important points from this document are? What did you hope the reader would get from it? Obviously, we're not looking to provide confusion, but it would be nice to know the types of questions that remain unanswered. And again, I thought it was a terrific document. So Jessica, what are your thoughts on the document as a whole in summary?
I think as a summary, one of the nice things was that we were all on the same page about, the basics of it being a common heritable risk factor. So present in about 20% of the population. It should be measured in everyone, all adults, with focused screening in children. And I think that really, that's what we're seeing with a lot of the guidelines really coalescing on this concept. And that we, all eagerly await the secondary prevention trials and, the data. But in the meantime, there is a lot that we can do. We can control other risk factors. And I think everyone was really, behind that concept. We can advocate for more education and further understanding of the biology, like Marlis mentioned. And so I hope that people come away with renewed enthusiasm for identifying this risk factor, and educating their patients and colleagues.
Thank you. Marlis, your thoughts?
That was outstanding. There's not a whole lot I can add to that. Very, very nice summary of this document. I do think it was an honest document in terms of what we know and what we don't know, but also the challenges, and Jessica's alluded to those. And, I think it nicely identified the key stakeholders, that, we need to be targeting with messaging, and that the messages are different for different stakeholders. They need to be. Like, we have a whole section on key educational messages for clinicians. And I think that's really important to separate out, what the needs are for these different stakeholders. What do we need to do for education for patients? We had a section on that. Education is obviously very important. And then, just generally how to navigate, which is something, again, this is in Jessica's wheelhouse, but I was very interested in the implementation science aspect of LPA and the use of LPA in clinical practice. I was very intrigued by that, and I thought that discussion was really good and nicely summarized in this document. But, it's all about, kind of the pathway of, seeing a patient, measuring their LPA, how can you do that within, the existing electronic health record system, and I'm not familiar with the US system, but could there be prompts? Could there, and what do you do with the information once you get it? And that's where I found the document to be very honest and helpful, because, yeah, it's great to say measure it, once in everyone. But at the same time, I think this document went deeper to, okay, but what are some of the barriers to that? And that's what I really liked about the document. And I just sat back and listened to that, because that's not my area. But again, I reread the document just now, like, in the last couple of days, so I'd be familiar with it. I'm like, darn, this is good. Because, and then getting even around to, some of the fundamental science questions, which again, I thought were covered honestly and fairly with really good participation by the group and contribution. But you can see how, it's from that understanding that new approaches can be developed, and further understanding. And I think I'm always kind of getting to, when we have drugs, who really should be getting them? How are we going to define that population? If we don't really understand the risk, that, the basis of the risk completely, all of better understanding of all of these things will help us to be more specific and targeted about how we utilize these wonderful, pharmaceuticals that are coming to market, sooner than, I think anyone anticipated. This has all gone very fast. And so yeah, so I think it's a good forward-looking document.
Okay, I totally agree with, I'm sorry, Jessica, did you have a comment?
No, I said ditto, Marlis. That was a great point you made. It's simplistic to say measure it once, but what do you do? How do you find it in your medical
Exactly.
record once you measured it,
Exactly.
8 or 10
Exactly.
years ago? How do you dig it up? How is it at your
Yeah.
fingertips? Yeah. How does the
Yeah.
patient know that it was measured 8 years ago?
Right. Right.
This
Right.
is
Right.
important. Epic happily
Mhm.
has an elevated LP(a) code, which you can put in as a diagnosis. So if you do identify a patient, at least now, the least you can do is put it in as a diagnosis, because as we see whether the new therapies reduce cardiovascular events, you'll be able to retrieve those patients. So for those of you using Epic, I know that for a fact that there is a diagnostic code. But I appreciate both of your summaries. I think, for our audience who I, could be leaving a little bit confused, that's a good thing. There's a lot that we do know, and it was beautifully laid out in the prior Journal of Clinical Lipidology document on LP(a) and what we can do now. I encourage you to read that. We certainly can identify patients who are at high risk, who also have elevated LP(a). And it won't be long that we'll know whether reducing LP(a) actually reduces events. So it would be important to have those patients at your fingertips. And that's why you should be measuring it, at least in patients with atherosclerotic vascular disease, and documenting in the chart that they have it, in the hopes that these studies will show clinical outcomes. But what this paper did, which I think is equally important, is it gives you some ideas of what we know and what we don't know. And I think that's it's very readable. It's worth it to our audience members who are going to need to know about LP(a). It's going to be probably for the next decade one of the important topics in preventative cardiology. And this document gives you the things that still need to be investigated, as well as some guidance on the pediatric population, valvular disease, et cetera. So I'd like to thank both of my guests, Dr. Jessica Pena and Dr. Marlis Koschinsky, for your tremendous expertise. And thank you both for your contributions to this really wonderful article. Again, not only is it intriguing in terms of the things that we know and don't know, but it's really beautifully written and easy to read. So greatly appreciate that. I encourage all the audience members to take a look at it. Again, it's called What's Next for LP(a), a National Lipid Association report from an expert panel discussion, published in the September 18th issue of the Journal of Clinical Lipidology. Thank you again, both of you, for your expertise and great thoughts on the topic.
Thank you, Alan.
Thank you, Alan.